Good evening, everybody, and welcome to the PHN live stream studio for another one of our live stream events this evening. Before we do get started, my name is Scott White and I'm the Communication Manager for the PHN. I'd like to acknowledge the traditional custodians on all the lands that we're meeting on across our region tonight and pay my respects to elders past, present and emerging, and also to welcome any Aboriginal people that are viewing the seminar tonight, the workshop, and also who would perhaps watching it as a recording later on. So thanks very much, and also probably really acknowledge that this particular topic, immunisation, is a really important part of our strategy in actually closing the gap. So it's a really important information for looking after our Aboriginal brothers and sisters. So before I leave you, I would like to introduce Patrick Cashman, who is the rock star of immunisation in our region. Perhaps, you know, Newcastle's the silver chair of immunisation, the Joey Johns of vaccination, perhaps, Patrick. So anyway, I'll leave you in Patrick's hands and enjoy the workshop. Thanks, everyone.
Hello everyone, thanks for tuning in from your lounge rooms, kitchens and probably your little homemade French restaurant on Bastille Day, so that's fantastic. And we've got a treat for you tonight. We've got some wonderful guest speakers. First up we've got Dr. Sonia Ennis, who's the Program Manager for Immunisation in New South Wales. Whatever runs smoothly in New South Wales with immunisation is down to Sonia. Whatever doesn't quite run so well, that's the Commonwealth. And then after Sonia, we've got the Indigenous National Program Director, Katrina Clark, who's from Ivanhoe in Western New South Wales, but lives here in Newcastle. And a lot of the program changes that we want to talk about tonight, the new schedule, changes with Aboriginal vaccination, and Katrina's going to give us some really good background to that. And I'll talk a little bit. And then we've got two wonderful practitioners in Erina, who's going to talk about how to give the vaccines, where to give the vaccines, the really practical. So we've left that to last because we know that's what you're really interested in, so you'll stay tuned. And I'll hand over to Sonia now. So thank you very much, Sonia. So Sonia's in Sydney, so she runs the whole state from there, and we really thank you for giving us your time and tonight. So I hand you over to Sonia. Thanks, Sonia.
Thanks, Paddy. Can you hear me okay?
Yes, Sonia.
Okay, lovely. Just wanted to check because I've had some technical issues earlier. So thanks very much for inviting me here to present at your webinar tonight. You know, I really feel very privileged to be asked, and it's a great opportunity for me to be able to share with you what things are like within the ministry and the kind of issues that we're seeing throughout New South Wales with regard to immunisation programme implementation. So the first slide, Paddy, is that the photograph that's up? Yes. So I just want to introduce my team. Back once, Paddy, sorry. I wanted to introduce my team. This is a small team, so we're a very small team, and we are responsible for implementing New South Wales immunisation programmes. We've got the school vaccination programme, we run the vaccine centre, we look at a budget of $137 million, and we have healthcare worker vaccination, pharmacist vaccination. There's a whole range of topics that we're involved in and programmes that we're responsible for managing. And I'm very lucky to be part of such a very productive team and a very friendly team. We do have some fun. Next slide, thanks, Paddy. So tonight I wanted to give you an overview of immunisation coverage rates for Central Coast and Hunter New England and how you're comparing to the state and national coverage rates. And I'll just present you with the latest data as at March because we're still waiting for the June data to come through. I'll also give you a little snippet about the winter flu vaccination programme and reporting to the AIR, I've dropped off a word there, Australian Immunisation Register. I'll give you some data on the school vaccination programme. I'll talk to you about our programme benchmarks that we're responsible for reporting to the Commonwealth on. And finally, some issues that we've identified that are happening throughout the state and potential solutions. So hopefully it'll be interesting from a programme management point of view. So next slide, thanks, Paddy. So this one, I love this picture. The little girl says, vaccinated because my mum leaves the research to the professionals. I thought it resonated quite well. Next slide. Thanks, Paddy. So how are we performing? So this is the data as at the 31st of March this year, and this is for all our 1-year-old children. And you can see that both LHD, Central Coast and Hunter New England, are performing exceptionally well for 1-year-old children. New South Wales coverage is 94.5% and the national coverage, but you're both above that, both above the 95% target that we aim for, so that's exceptionally well done. For Aboriginal children, so I think moving on to the side, for Aboriginal children at this age in the Central Coast, 94.3% of children are vaccinated, and in Hunter New England, 95.2%. So it's still really high coverage rates for our 1-year-old children, which is fantastic. Next slide, thanks, Patty. This is coverage for our 2-year-old children as at March. Now there is a drop in the 2-year-old children coverage because there has been a change in the schedule, and that generally drops the coverage at this age down by a couple of % before it picks back up again. But not in Central Coast or Hunter New England. We can see that you haven't dropped. You're at 93.31% for Central Coast and 93.82% in the Hunter New England LHDs. So that's fantastic. You're doing an exceptional job. For Aboriginal children in the Central Coast, it is lower. It's 86.4%. And in the Hunter, it's 91.8%. So we do have a dedicated program where we have our Aboriginal immunisation healthcare workers in who pre-call and call families. However, we do acknowledge that the data can be a little bit, can move around a lot, bump around a lot because the numbers are small. Next slide, thanks, Patty. This is our 5-year-old children, and this data is, you have to give yourselves another pat on the back. Central Coast and Hunter are both above 95% compared to the state and national averages of 93 and 92%. For Aboriginal children, it's unbelievable as well. In the Central Coast, it's 98.7%, and in Hunter New England, 97.5%. So this is tremendous work that is happening within your LHDs, and I can't thank you enough for the hard work to get these high coverage rates. So the next slide, please, Patty. It would be very remiss of me not to mention our winter flu immunisation program. It's been a very difficult program this year, particularly because of COVID-19. We forecast the number of vaccines that we need. We do that back in October or November of the previous year, and no one could predict that we were going to have a COVID-19 pandemic. We developed a range of resources, and we've actually found that a lot of providers weren't aware of those resources. So for next year, we need to consider how we can get communication out to practices, and some suggestions have been made through the Practice Nurse Association or practice managers as well. So we need to have a debrief and think about how we can get information out there, because we did develop a toolkit, which is the top left picture on that slide. The bottom left photograph is of a calculator that we developed so that you could determine how many vaccines you needed for each of the cohorts who are at risk of flu this year. And on the top right is a flyer that we developed that we thought would help for identifying which vaccines for which cohort, because there are so many vaccines for flu for each of the cohorts, and it can be quite confusing. But nevertheless, the program did go ahead and it was successful. If you want to go to the next slide, Pat, I just wanted to share with you all the number of vaccines that we have distributed in this season. So this is a graph that shows over the last 5 years of flu vaccine distribution data. And you can see for the bottom two curves that we would have distributed about 1.3 to 1.5 million doses in any usual year. We got the vaccine into the warehouse and we distributed it, and the flu program ran very smoothly. Then I took over this role as a manager. I don't know if someone was trying to spite me, but for the last 3 years, we have been 2.3, 2.4 million doses being distributed, and this year has been a mammoth year, and obviously in recognition of that we're in the middle of a COVID pandemic, lots of people were wanting to get vaccinated and there was lots of media around. We are just sitting at just under 3 million doses, and that's only since the end of March that we've distributed that. So during April and May and June, in 3 months, we've distributed 3 million doses. Now, when we opened up the flu vaccination program ordering, we said there were no restrictions on the vaccines that could be ordered. Some practices over-ordered, and we're finding out now that they've got too many vaccines in their fridges, and our primary health network colleagues have been very helpful in trying to relocate those vaccines under the cold chain. Meanwhile, other GP practices didn't order enough and didn't realise that they needed to order enough in the first order to keep them going for the first 4 weeks. And so there was a few difficulties there. So we will be having a debrief this year to try and identify how we can get vaccine out there more equitably, given that the last 3 years vaccine distribution has increased dramatically. Next slide, thanks, Paddy. This slide here is just to show you the doses that we distributed versus the doses being reported to the air. Although you must note that the doses being reported to the air includes private and NIP vaccines. But the one that I really wanted to point out to you is the over 65-year-old cohort vaccine, the Fluad Quad. Now that vaccine was only made available through the NIP, through GP practices and AMSs. So it couldn't have been made available, it wasn't made available through pharmacies and other private providers. So of the 1.3 million doses that we've distributed, only 876,000 have made it to the air. So there's 500,000 doses somewhere out there in GP practices, AMS practices, fridges, and we need to find those doses. And as I said before, we do have some practices that have come forward to say that they have way too many vaccines and we're trying to redistribute them. So we need to think next year whether we will do pre-allocation of doses, vaccine doses, based on previous year's orders, or how we're going to work it, because with this level of demand and number of vaccines that are going out, we need to probably change how we do things, because what we did in the past worked, but it doesn't seem to work now. Next slide, thanks, Paddy. And then this last slide about flu vaccine, this is national flu reporting, so it's the whole of Australia flu reporting. But just to show you that from 2018, there were 4.6 million doses reported to the air, compared to 8.7 million doses reported now in 2020. So that's nationally for Australia. And given the population of Australia is around 23, 24 million, it's not, obviously there's a lot of underreporting, vaccines not making it to the air, but it still shows you how much it has increased over the last 2 years alone. Next slide, thanks, Paddy. This slide's just to show you, when we get complaints and people that are concerned and writing to the health minister, it makes its way to our team. And a lot of people are really concerned about catching flu because they haven't had the flu vaccine. So we would refer them to data or mention that there isn't much flu around in the community. And this graph can show you that the range and average for the previous 5 years, which is the blue shaded area and the blue dotted line, is rather high compared to this year, which is the red line. And there's very little flu disease in the community at the moment. And if we just go to the next slide, there's a summary. I've just provided a summary of where we're at with flu. So the testing numbers are high, probably because of COVID, but we have low rates of flu being detected. We haven't had any influenza deaths, and we haven't had any influenza outbreaks in any institutions. Normally we have a number of aged care facility flu outbreaks, but thankfully none this year so far, and that's as at 5th of July. But there is a lot of rhinovirus in the community, which is higher than usual for this time of the year. And if you are interested in looking at these reports, I've provided a link here to those reports. And these slides will be made available afterwards. Next slide, thanks, Paddy. Now, I understand from the audience that Paddy has told me is that we have some nurse immunisers from the school programme here. And regardless of whether you're involved in the school programme or not, if you work in general practice, you would have adolescents coming to your practice as well, seeking vaccination. So just thought I'd share a couple of slides on how coverage has been impacted with COVID this year, because we did have to suspend the Year 7 school vaccination program, which offers HPV vaccine, human papillomavirus, and diphtheria, tetanus, and pertussis vaccine. And suspension of that program has impacted on coverage rates. And public health units now are busily catching up students in the schools, and that catch-up will probably extend way into next year as well. But this first slide here is for our male coverage for HPV vaccine, and it's showing you, it's really the last column that I wanted to draw your attention to, the difference between this time last year's coverage and this year. So in Central Coast, it's dropped by 1% for males receiving HPV. And that's possibly because Central Coast teams were able to get in early and get the first dose of HPV vaccine administered before the programme was suspended. And in the 100, it's dropped down by 23%. But it is a larger region, and there's many numbers of nurses teams out vaccinating, and it just depends on when schools were booked over that period whenever the school programme was suspended. So the next slide, thanks, Paddy. This slide is for females for human papillomavirus vaccine in the Central Coast. Compared to this time last year, it's dropped by 7% compared to 21% in the Hunter. Again, it's around when the schools were being offered dose 1 in those LHDs, and also when the programme was suspended. Some public health units were lucky to be able to gain access to some schools before restrictions before the schools closed. Next slide, thanks, Paddy. This is a diphtheria, tetanus and pertussis programme, which is offered to year 7. Similar decline, 3% and 21% in both LHDs. Again, this vaccine would be offered at the same time as the HPV vaccine, so there's no real surprises there. The next slide, thanks, Paddy. This is the meningococcal ACWI that's offered to year 10 students. And with this one, we were given a directive through the Commonwealth that we should try and offer this vaccine to our year 10 students somehow, whether schools are closed, whether we could offer them through community centres. But in reality, that was very difficult because lots of the nurse immunisers were called upon to assist with the COVID surge. So it was very difficult to do that. The reason why the Commonwealth wanted us to continue with the meningococcal ACWI vaccine was because it's typically higher in winter time and they wanted to get the students vaccinated before winter. But they are being vaccinated now. It has restarted again. And we did develop some guidelines for implementing the school vaccination programme in liaison with the Department of Education, the Catholic Education Ministry and the AI Independent Schools Association. So it is happening and there'll be lots of catch-up happening. So students may turn up to GP practices who have missed out vaccination as well, and we do have detailed information on our website as well. So that's the last part of my presentation. So the next slide, thanks, Paddy. This last part of my presentation, I wanted to share with you where the buttons are pushed from the Ministry's point of view. So we implement the National Immunisation Program under a national partnership agreement with the Commonwealth. It's called a National Partnership on Essential Vaccines. And if you Google that, you'll find the partnership. In that partnership, there's 5 performance benchmarks and 1 milestone for all states and territories. And if we meet those benchmarks, we attract a performance payment. And if we meet the milestone, which is reporting the HPV data, the school vaccination data to the air, we also receive payments, performance payments, and that equates to $800,000 per benchmark and $300,000 for the milestone. So there's a lot of money that is associated with each of these benchmarks, which I'd just like to explain to you. So when we do write out to practice and there's information coming from us, there's usually a reason behind it that we do have benchmarks that we have to meet. If we don't receive that funding, then the knock-on effect is great because it limits what we can do within the districts and also funding to our public health units to implement immunisation, the school immunisation programme. Next slide, thanks, Paddy. So these benchmarks, there's 5 of them. So the first one is an increase in vaccination coverage rates for 60 to 63-month-old children. That's our 5-year-old children. The next benchmark is an increase in vaccination coverage rates of our Aboriginal and Torres Strait Islander people in at least 2 of 3 cohorts. And that's for our 12 to 15-month children, so our 1-year-olds, 2-year-olds and 5-year-olds essentially. It's described in the agreement as 12 to less than 15 months, but it's essentially our 1-year-olds, 2-year-olds and 5-year-olds. We also have to increase the vaccination coverage rates for adolescent boys and girls for HPV. And when it says relative to the baseline, that's based on the previous year. So if we've done really well in the previous year, then we have to do even better the next year. The fourth one is an increase in coverage rates for our 5-year-old children in 4 of our 10 lowest coverage areas. So the Commonwealth provides us with SA3 data, which I'm sure you're all familiar with, and we choose 4 of the areas that we feel that we can achieve an increase in and that work can be done. And we work with public health units, and there are certain initiatives that are undertaken in those areas to try and improve vaccination coverage rates in those areas. And it can be difficult because typically those areas are up in the northern New South Wales coast or out in the Blue Mountains area of New South Wales, and some of the northern Sydney metropolitan areas as well can have low areas. So it's quite a difficult indicator to meet. And the last one is an annual decrease in wastage and leakage rate for some vaccines, and it's all mostly childhood vaccines and those that can't be used in adults. And this is the hardest one that we struggle with, and we failed it in 18-19, despite having done a considerable amount of work around vaccine cold chain management, but I'll talk about that a little bit later. Thanks, Paddy. Next slide. So with this agreement, we find lots of issues, and what we've identified so far, and this is not meaning to be critical, but it's what we see at the Ministry throughout all of New South Wales. And a lot of it is metropolitan related, but there are rural and remote area issues as well. So the biggest one, and I'm sure you're all familiar with this one, is underreporting to the Australian Immunisation Register. On average, the Commonwealth would allow 3% underreporting when they're calculating our data, but we know it's much higher than this in some areas. We know that in some areas of New South Wales it can be as high as 22 to 23% underreporting. And pre-COVID, we had undertaken work that we were going to work with the public health units in improving reporting to the air, and then COVID hit, so that research project is on hold at the moment, but we would like to work with our primary health networks and public health units and trying to reinstigate that project when things settle down. We're also made aware of practice software not being updated, and that affects the air reporting. Today we had a meeting and I've been told about medical director when they're using the financial part of that, and I need to check my notes as to what that's called. It's PracSoft billing program. If there's no Medicare number in that PracSoft billing program, apparently it doesn't make it to the air, there's no notification provided either. So a provider may use a medical director using the PracSoft billing program, think that the notification has gone to the air when it hasn't. So that's something I'm going to take up with the Commonwealth that we've just been made aware of. There's also data cleansing, and we used to have the business development officers come around, practices and help with data cleansing, and that stopped a number of years ago, and it's something that we've been told isn't happening regular as it should be, so maybe a little bit of work needs to be done there. Our biggest issue that we have is storage of vaccines. At the moment, I'm dealing with 6 medical practices. They're all in the metropolitan area that have removed their vaccines from their original packaging and had them stored in a glass front fridge. And this has been happening for we don't know how long. So we're now going to have to work with the National Centre for Immunisation Research and Surveillance, NCRs, which I'm sure you're all familiar with, to try and work out a process as to what we can do to try and identify which patients would have received those vaccines. And it's private and NIP stock, so it's going to be quite a huge body of work to work through this. So if you have vaccines that are not been stored in their original packaging, please don't do that any longer. Also, we find where vaccines are not being rotated and expired vaccines are being discarded or they're being administered, even worse. And we've also had cold chain breaches happening, and I'm sure you're all aware they've happened in the metropolitan area in particular, where it has resulted in recall and revaccination of a few thousand patients and has made the newspapers. So it certainly is an issue from our point of view, particularly with fridges and the plugs being pulled out or they're not being refrigerated upon delivery. There's no backup plans or storage equipment during power outages as well. We also have issues with vaccine leakage, where they're being administered to non-eligible people. So we'll have to do a little bit of work around that. That is part of that benchmark of wastage and leakage. We think that we're pretty good with vaccine wastage. It is improving using thermostability data, and practices have come on board exceptionally well with that. But leakage can also be where it's not administered to non-eligible people, but also where it just doesn't make it to the air. When the Commonwealth does their calculation for that benchmark, they look at the number of vaccines that they have sent us to our warehouse, the number of vaccines that have been distributed to providers, and the number of vaccines that make it to the air, minus 3% because of underreporting to the air. And that's why we failed that benchmark, because we think that there's a lot of vaccines that are either sitting in fridges or they're just not being reported to the air. So we've got a little bit of work to do in that space. And finally, there's probably not a week goes past that we don't find out about administration errors where the Hib pellet hasn't been reconstituted with the hexa, and it's a very simple one. And you know, the nurse immunisers and the doctors that do it have been terrible afterwards, because you know, have to call the patient back to get vaccinated, and you know, any kind of administration error reduces vaccine confidence in both the public and with the patients as well. So these are the key issues that we see regularly within the ministry. Next slide, thanks, Paddy. So how can we meet some of these benchmarks for the NPEV? So it's very simply reporting all of the immunisations to the air, and that's childhood, adolescent and adult. quite often the adult, you know, I mean, we have high coverage rates for our childhood program, but it would be wonderful if we could get higher adult immunisation rates now that we have the AIR as an all-of-life immunisation register. Rotation of stock so that the expiry date of vaccine, the shorter expiry date of vaccine is used first, and keep vaccines in their original packaging. I can't stress that enough. Develop salvage plans to minimise your wastage, and only order the amount of vaccines needed. So calculate it, don't guess it. We are going to. There was an old tool, a tool that was used quite a few years ago under GP New South Wales, and I'm sure Paddy and those of you that have been around for a while would remember this. I think that it was calculated on your stock in hand, what you ordered, what you've used, and that determined what you needed to order plus 10%. So we're having a look at that at the moment. We're doing some work within our team to try and identify how we can help providers to calculate the vaccines, the amount of vaccines that they need, so that we don't have situations where fridges are stocked and then if there's a power failure, there's a huge wastage. We've had wastages that equate to over $20,000. So what we will also do is provide that dollar amount to providers when there has been a huge wastage. There is some thought when we've reported amounts of the cost of vaccine wastages, there has been some feedback that they're free, but they're not actually free because it's taxpayers' money. These vaccines have to be paid for. They may be provided to providers free, but they're typically not free. They cost millions and millions of dollars. So we just need to get the messaging out there. We are in the process of finalising a GP toolkit. We did one quite a number of years ago, probably about 5-6 years ago, and we're in the process of finalising another one and perhaps being able to print one and send it out to all of our providers. We did receive lots of good feedback about that toolkit, so we think that might be helpful as well. Next slide, Paddy. I'm nearly done. I don't want to take up too much of your time. But it would be also remiss of me not to mention COVID-19 vaccination program. There's lots in the media. I think we turn the news on every evening or every morning, and we hear about all of the developments about COVID-19 vaccine trials, and they're injecting it into people, and that they should have a vaccine ready by Christmas. I don't think there'll be a vaccine ready by early next year, but you know, I could be wrong. But what we're doing at the moment within the ministry is developing a plan. So we have started our planning. We're developing an options paper at the moment, but there's so many unknowns. For example, will it be an annual program like flu, or will it be a one-off dose that could give you lifetime immunity? Will it be a single dose or 2 doses in the first year? Who will the priority populations be? Will it be a mass vaccination clinic versus routine clinics? Obviously, we have the flu pandemic vaccination plan, and we have a vaccination plan for that where it's associated with mass clinic rollout, but we don't know enough at this stage, and a lot of this would also be determined by the Commonwealth. So we're busily planning away in the ministry at the moment, and obviously will involve primary health units and networks and stakeholders when time is correct or when the time is nearer. But at the moment, there's nothing just yet at the moment. Next slide, thanks, Paddy. Look, I wanted to put this slide up. This is just to remind you, why we're all here and what a great job we're all doing. I was just doing a search through the internet today and found a lot of these old photos, and I'm sure you remember seeing photos of the iron lungs, the children with polio and the crutches and the calipers. That top right-hand photo, when I got vaccinated at school, we lined up, we stood in the line, and the nurse walked along our line and vaccinated us. And I don't think I was asked even one question. So we've come a long way since then. And the little kid in the bottom right-hand photo lying in the iron lung with the mirror talking to someone on the phone. So, vaccination has come a long way. We have come a long way, and with immunisation, it's forever changing. And there's many, many drivers with the programme, like the Commonwealth, like agreements, like things that are happening in the community, new disease emergence, just takes over everything that we do, like COVID. So I hope that's been helpful, and obviously I'd be very happy to answer any questions later on. And the last slide, thanks, Paddy. So thank you all just for your attention, and I thought this was a very cute photo. Normally the photos we see of kids being vaccinated, they're usually screaming, so when I saw this one, I thought I better put it up. I thought it was quite a nice photo. Thanks, Paddy, and thanks everyone.
Wonderful. Thank you very much, Sonia. I really appreciate you coming to give us that big picture stuff, what's happening around the state and where we fit into it. And there's hundreds of people in their lounge room around Gosford and Central Coast and Newcastle and Hunter, New England. Really thank you for your time. and giving us that big picture stuff that we normally don't get an insight into. So thank you very much, Sonia. And it gives me great pleasure to introduce my good friend Katrina Clark. Katrina's going to talk about the new schedule from an Aboriginal point of view, because a lot of the vaccines are there to overcome a lot of the Aboriginal disadvantage with bad health, and Katrina's going to give us some insights into that. So Katrina actually works at the National Centre. Her job's national. She used to work here in the Newcastle team, but she's gone above and beyond now. We really thank Katrina for her time giving you these insights.
Well, thank you, Patty, for a lovely introduction for that. So we'll just wait till my slides come up. So prior to starting, I would just like to acknowledge and pay my respects to our ancestors, our elders, past and present, for their strength, resilience and their wisdom. And as a proud Barkindji woman as well, I would like to also extend that acknowledgement to our non-Indigenous colleagues online this evening that walk with us to continue to support the best possible outcomes for not only today but in which ways all health services are provided to Aboriginal and Torres Strait Islander peoples and their communities for future generations. So tonight I will be providing just a brief overview on existing opportunities for improvement and highlighting the inequalities in disease burden and vaccination coverage for Aboriginal and Torres Strait Islander communities, as well as discussing the rationale behind the current immunisation schedule, as well as explaining the rationale behind as well the upcoming changes that came into effect on July 1. So the reason why I and many more Aboriginal healthcare professionals advocate for cultural capability in the healthcare system is because we hear so many times is, I treat everyone the same. And in actual fact, when we talk about equity and equality, we actually can't give everybody the same thing because people have started in a different place. And in the case of Aboriginal and Torres Strait Islander Australians, if we look at policies past and present and the laws that prevented my grandfather, my grandmother, my mother and we Aboriginal and Torres Strait Islander peoples from progressing in society, these ongoing effects and forced separation of families, entrenched discrimination, and followed just by our inequalities of our basic rights. So we're already behind the 8th ball. So it's kind of like if you've ever seen this image on the screen now of the fence. If we continue to give everybody the same box to see over the fence, nothing changes, and we have to give people what they actually need to be able to achieve equity in Australia. So simply put, it means Aboriginal people, we require the additional vaccines. So you may need to work differently to ensure that this occurs. So doing the same thing, we're actually reproducing the inequity, and it's not the same. What we need is fairness. So trying to solve the inequity assumes that we all have the same opportunities and experience. The reality is that Australia's first people continue to experiences with racism makes this untrue. So only when we address the inequalities can we truly be it can only be truly levelled. So from a level playing field. So let's talk about the disease burden. So a lot of what I'm going to be talking about or showing you tonight, it comes from the NC's reports published late in 2019. So it's historically, immunisation has been and remains a safe, effective and affordable way to improve Aboriginal and Torres Strait Islander health, delivering positive outcomes for people of all ages. However, Aboriginal and Torres Strait Islander children, still experience higher rates of vaccine-preventable diseases compared to non-Indigenous children. So during this presentation, I really hope to answer those few questions to why the NIP schedule is different for Aboriginal and Torres Strait Islander children. Here we can see the rates of invasive pneumococcal disease notification by age and Indigenous status in Australia between 2006 to 2015. The burden of this disease remains higher in Aboriginal children despite long-standing vaccination programs. As you can see by the solid blue line, it's 3 times higher in less than in our 5-year-olds. And then as you can see by the red line, the solid red line, it's 10 times higher in the age group from 5 to 49 years and 6 times higher in our over 50-year-olds compared to the non-Indigenous Australians. You know, the recommendations for the pneumococcal vaccination program has changed in Aboriginal and Torres Strait Islander people as of July 1. As well as adults and those at with medical risk factors. But, so these will be also explained in greater depth with Patrick following my presentation. Meningococcal disease, so it's pretty rare, but it's a serious infection. This graph shows the rates of pneumococcal disease notification by all types by Indigenous status and in Australia between 2006 to 2015. As you can see by the solid red line, meningococcal disease notification have almost disappeared since the commencement of the meningococcal C vaccination program in 2003. However, meningococcal B disease rates remain several times higher amongst Aboriginal and Torres Strait Islander people than other populations. It's 4 times higher in our under 5s and 6 times higher in our 5 to 14 years of age. Subsequently, the period covered in this graph, meningococcal W and Y strains have also emerged as a cause of disease, with much higher rates in Aboriginal and Torres Strait Islander people. Meningococcal ACWY was added to the NIP in 2008 for all children at 12 months of age and adolescents for 15 to 19 years of age. However, should we also be giving additional meninge ACWY to Aboriginal and Torres Strait Islander children 5 to 14 as well, given the rates that we can see on the screen. This is the recent data of meningococcal B notifications for Aboriginal and Torres Strait Islander people compared to non-Aboriginal people by age group from 2016 to 2018. So as you can see, the disease is more common in children less than 12 months of age. So it's 6 times higher in less than 12 months compared to non-Aboriginal children. And then it's 2 times, so I'm not sure if I can use this little, yep, and then you can see it's 2 times higher in our 12 to 23 months of age compared to our non-Indigenous children, and then 11 times higher in our 2 to 4 years compared to non-Indigenous children. And then 7 times higher in our 10, so that's 10 to 14 years of age. So the good news is the inclusion of the meningococcal B on the NIP as of July 1 for Aboriginal children up to 2 years of age and other risk groups. So I really hope tonight by showing this data and showing this graph that it really highlights the importance as well of why Aboriginal children are receiving the extra additional vaccine is because of this graph as well. So now he's a real success story at a national level, that the great example of equity, of giving people what they need to reach their best health. You know, prior to the introduction of the hepatitis A vaccination program in 2005, the rates of hepatitis A disease was at least 5 times higher in Aboriginal and Torres Strait Islander children than other Australians. Following the introduction of the program in 2005, Aboriginal and Torres Strait Islander children aged 12 to 24 months in Western Australia, South Australia and the Northern Territory, so the 4 jurisdictions with the largest disease rates, so we can see here that those notification rates in those children has sharply declined and have remained lower than those other Australians since 2007. So from July 1, these states and territories, so this does not include New South Wales, so the funding for hepatitis A vaccine and the new schedule points will be at 18 and 4 years of age. So the schedule point, it changes to the 4 years of age for those jurisdictions. So I just wanted to show this graph to show you and highlight like the importance of why Aboriginal and Torres Strait Islander children, that we do need that extra additional vaccines. So in summary, tonight I've shown you that despite the successes, there are still disparities in the number of vaccine preventable diseases, and we needed to enhance the NIP. Vaccine coverage is pretty good, and in fact, the latest coverage shows immunisation coverage rates for Aboriginal and Torres Strait Islander children at a record level of all ages. So, you know, we have a high vaccination coverage rates across all ages, so we really do need to keep it that way. However, delayed immunisation and vaccine preventable diseases remains a significant health issue for Aboriginal and Torres Strait Islander children. So this is why we really do need to make a focus on making sure that all Aboriginal and Torres Strait Islander children receive their scheduled vaccines on time. The changes to the NIP will improve 2 diseases with high burden for Aboriginal and Torres Strait Islander children, so that's the pneumococcal and meninge B. So as I said throughout the presentation, I really hope that you can all see now, so the reason for the essential changes in the NIP and the importance of Aboriginal and Torres Strait Islander children receiving all their routine vaccination on time. So this is including the meningococcal B vaccine. So what can we do as a service provider? So Indigenous issues, it can be Aboriginal and Torres Strait Islander issues, it can be daunting, and it's easy to slip into a state of helplessness and convince yourself that nothing you will do will help, or you're scared to try in case you do something wrong. But it should be more about your responsibility as a human being and as an Australian to understand the situation in which Indigenous people find ourselves in, and how you can be empowering and a positive force in fighting for the rights of the people of this beautiful country. So it's important to identify Aboriginal and Torres Strait Islander clients and families. So just the importance of identifying your Aboriginal and Torres Strait Islander clients. So this ensures, you know, the care and the service provided are both clinical and culturally responsible. So deciding if a person is of Aboriginal or Torres Strait Islander descent based on looks, features, appearances, this is not reliable or appropriate. You know, the only way to really identify your clients is to ask the question if your families identify as Aboriginal or Torres Strait Islander. You know, the correct identification also helps you provide referrals to other services such as the recommendations for screening and health checks, referrals and linkages to external services that are designed for Aboriginal and Torres Strait Islander peoples. And just to be aware as well of the changes that came in effect on the NIP schedule and the variations as well between states and territories, because we do have a lot of families that are transient as well. So, you know, we visit mob all over the country. So just to be aware as well as the differences between state and territories schedules. And also just to try and continue to offer immunisation opportunities at all visits. So the much of healthcare sector treats the illness in Aboriginal people rather than promoting the good health and delivering that person-centred healthcare. So I think this is my last slide, yeah. And as the great man Nelson Mandela said, you know, it always seems impossible until it's done. So happy immunising everybody, and I really hope that I've helped you with the new schedule changes for tonight. Thank you.
Thanks, Katrina. That was fabulous. Person-centred healthcare. How cool is that? What a great phrase. Something to take home with us. So if you're just back from boiling the kettle or having another glass of wine, you've tuned into the Primary Health Network, Central Coast and Hunter, New England, talking about the changes to the immunisation schedule, and luckily we've had Dr. Sonia and Katrina give us some great background. I'll talk about the schedule changes in a minute. We've also got some Donna and Julianne on standby in Erina, who are going to talk about some practical immunisation administration issues shortly. And in the background, Jodie Stevenson and Sharon Saxby are answering questions on Slido. So if you're not watching this through Slido, you can go to slido.com and use your password, which is NIP, which stands for National Immunisation Program, which is all the funded vaccines, which is what we're here to talk about. Then type in your questions for the presenters. We'll also have a Q&A afterwards here live in camera, but if you want to type your questions in, Jodie and Sharon are amazing in providing fantastic answers, which they do all day, every day, but specifically on Slido tonight. And then don't forget to provide your feedback after the session by completing the feedback form in Slido. My beautiful assistant is just changing the slides. Thank you, Todd. So Todd's the sound guy, makes us all sound good. He even gave Sonia a wonderful Irish accent, which was terrific. So I'll talk about the immunisation schedule changes and point out a few things. Normally we do this live. If you like this sort of format, then please do feedback in the feedback on Slido. So this is the schedule, the New South Wales schedule, which is the best one to use because it's specifically to our state. It's some interesting, this is the previous version, and up on the left-hand side of the screen, if you look carefully at the 4-year-old mark there, it's got diphtheria, tetanus, pertussis and polio at 4 years, which is what you'd expect. But underneath a dark line, just atop of it, is the 18-month vaccine, Haemophilus influenza type B. So if you weren't that familiar with the schedule and you just looked at that quickly, it would be easy to think you'd have to give the Haemophilus at 4 years of age. So that schedule's been changed to now look like this, so that there's quite good demarcation between the 4-year and the 18 months. So if you do have one of the previous ones which were distributed, suggest you responsibly dispose of it and print off these ones, and these ones will be around in hard copy soon. So this just for people who might not know the schedule as well as yourselves. I'll just save any errors there. So we'll talk about the new vaccine schedule changes, and a good way to think about it is the routine infant schedule and routine older Australian schedule, and there's changes there in the routine older Australian schedule, and the at-risk schedule. So Katrina's been talking about Aboriginal people who are at higher risk of disease, and that's why those vaccines are offered. And in the at-risk section, there's the medically at-risk, behavioural and Indigenous people. So that's one way to think about it. So this is a good way to have a look at it, although it looks a bit complex. So down the left-hand side, we've got the vaccines that are new and funded on the schedule and their abbreviations. And then we've got sections for different people. So there's non-Indigenous older adults, then there's a section in the middle on people at risk, and then there's a section on the right for Aboriginal people that Katrina's been talking about. And then there's pneumococcal, and below that are meningococcal, Hib and Hep A. So I'm going to talk in two sections. So first we'll talk about pneumococcal, so the top section. So that's the Prevnar vaccine on the top line, and you can see there the Prevnar vaccine, there's a new recommendation, NIP funded for older Australians. Then you look in that middle section for people at risk, and the middle column there is people without a spleen, so functional or anatomical asplenia. And you can see there in all those sections there's new funded vaccines, which means that all the vaccines that people without a spleen require are now funded. So that's a whole new funding stream in the middle there. So that's great for people vulnerable because they don't have a spleen. And then pneumococcal, there's different at-risk conditions for pneumococcus. And then on the right-hand side, Aboriginal and Torres Strait Islander people. And you can see there the big one is the newly funded Bacterial vaccine, meningococcal B, for Aboriginal infants. So the two huge headlines are Prevnar for older Australians and Bacterial for Aboriginal infants. And we'll talk about the detail of some of the medical at-risk people. So this is the feedback from providers before that a list of A and B of pneumococcal at-risk groups was too complex, so now there's just one table for people at risk. Now all these people are recommended to have a Prevnar followed by a Pneumovax 23 followed by a Pneumovax 23. So that pattern of Prevnar, Pneumovax 23 is quite new and worth remembering because it'll carry you through dealing with a lot of people. Now, some of the people on that list are people who have CSF leaks or other things. Those vaccines are funded, and some people they're not funded. And Katrina's been through the reasons why they're funded for Aboriginal people. Now this is a new chart that's available, and you would have seen this in some of the literature, and this is worth putting up on the wall of your clinic. So we'll just work through it a little bit. So on the left-hand side are kids, and on the right-hand side are adults, and the middle column is everyone over 12 months of age who are medically at risk. So on the left-hand side, you can see there kids in New South Wales get a Prevnar at 2 months, a Prevnar at 4 months, and a Prevnar at 12 months. And you're sitting there at home saying, well, what's the difference? And you're quite right, there is no difference, it's the same. So there's no changes in that section. So that's easy to remember. Well picked up at home. But at-risk children, it's a Prevnar at 2 months and 4 months, like all the kids, but they get an extra Prevnar at 6 months. So 6 months is that vaccination that you really like to give because most kids just get one needle. But for kids medically at risk, they do get an extra Prevnar, then a Prevnar at 12 months, and then this is new, 2 pneumovaxes, one at 4 years and one 5 years later. So they're on time at 9 years of age. Now the immunisation handbook has some great graphics, some infographics on the online immunisation handbook. And you can get to this through the front page going to the graphics section, or you can get to it through the pneumococcal section. And you can see there the routine schedule, Prevnar at 2 months, 4 months and 12 months, or like we promote 6 weeks, 4 months and 12 months, is unchanged. And then children with an at-risk condition receive an extra Prevnar at 6 months, followed by 2 pneumovaxes at 4 years and one 5 years later. Now, if you're lucky enough to work in other parts of Australia, which hopefully when everyone stays at home and washes their hands, COVID will disappear a bit and we'll be able to do that again. Then the schedule's different in the states that have outback communities. So in the Territory, Queensland, South Australia and WA. So if you are going to work in those states, you've got to be aware the schedule's a little bit different. So they're kids, they're the first two columns. Now the middle column there is everyone over 12 months of age. So that's someone who's 18 months of age or 50 years of age, it's the same. So at diagnosis of a risk condition, it's a Prevnar at diagnosis, followed by a Pneumovax, somewhere between 2 months and 12 months. So 12 months is the recommendation, but it can be as close as 2 months afterwards. Then a second Pneumovax 5 years later. So if we have a look at that, so this is this pattern with people at risk. So it's a Prevnar, followed by Pneumovax, followed by Pneumovax. So the interval between the two Pneumovaxes is 5 years. The interval between the Prevnar and the Pneumovax is somewhere between 2 months and 12 months. And they're all the at-risk conditions listed in the handbook where these are recommended. So a CSF leak, trisomy 21. Now, but some of these are funded and some of them aren't. Which ones? Which ones are funded? Which ones aren't? You're asking at home. I can see you regaling the screen between glasses of wine. The more regaling, the more wine you have. And there's a wonderful table that actually tells you. So if you look on the right-hand side there, so there's no more list of A and B, all the recommendations, but some are funded. So all the recommended vaccines are here, all the conditions where these vaccines, pneumococcal vaccines, are recommended are listed, and the funding's there. So there's 2 funding columns with a tick. So there's for kids less than 5 years of age and for people over 5 years of age. So you can see there that someone's got no spleen, it's funded if you've got no spleen and you're under 5 years, or got no spleen and you're over 5 years. The same for HIV, same for cochlear implants and intracranial shunts. But different, so if you're diagnosing someone, they're coming in and they're complaining to you that they're urinating a lot, and you do their sugar and they've got diabetes, it's a new diagnosis, then it's recommended that diabetics get Prevnar on diagnosis, followed by Pneumovax, but it's not funded. Whereas if someone comes in and they've got renal failure, you diagnose them with renal failure, then it's recommended and funded that they get a Prevnar, followed by Pneumovax. So the other new thing with this schedule, with the changes on the 1st of July, is that there's a limit to 2 Pneumovaxes in your whole life. So just 2, that's all. So if you're seeing someone later in life and they've got one of these conditions where the Prevnar and 2 Pneumovaxes is funded, they may have already had 2 Pneumovaxes. You don't have to repeat them. 2's enough. 2 stop, but give them their Prevnar if they haven't had the Prevnar, which they may not have because it wasn't previously recommended. So one of the pharmaceutical companies has put this out, which you've probably got in your clinics, and that just more graphically displays the medical conditions where the pneumococcal vaccines are funded. So why are we going to give pneumococcal vaccine? So just a quick reminder that the Prevnar vaccine is a conjugate vaccine and the Pneumovax 23 is a polysaccharide vaccine. So these are vaccines against Streptococcus pneumoniae, and that's an encapsulated bacteria. So you can see the graphic on the left, you can see up the top a little skinny non-encapsulated bacteria and then a big capsule with a capsule around it. And that's what the Streptococcus is like. So the middle one there, that thing that looks like a Y is the antibody. The phagocytic cell and the antibody can't attack the bacteria because it's got that encapsule around it. And on the right-hand side, these sort of bacteria have other defences and can break down antibodies. So the way to get around that is to use a conjugated vaccine. So up the top there is a polysaccharide, which is a long chain of sugars, which is what we got with the Pneumovax 23, and a little bit that gets into the B cell that makes the antibodies, and you get a little bit of antibody on the right. And in the lower graphic there, attach a little bit of something that the body recognises, like a little bit of tetanus or a little bit of diphtheria, that gets into the cell much better. So it's a way of introducing the cell wall of the bacteria into the B cell. So it's like going to a party and you don't know anyone and you float around and you're not really sure about how to get in, how to meet people. But if you go with someone who's popular, like if I went with Katrina to a party, I'd know everyone, and then you can get in, and that's what the tetanus or the diphtheria does because the body recognises it. And then once that's in, it can activate T cells. So T cells really help the production of antibodies. So they're T helper cells, helpfully named T helper cells, so easy to remember what they do. So you get much better immunity. And that's why Prevnar is now offered for the first time for older Australians. So if we look on the right-hand side now, so we've looked at kids, we've looked at people at risk in the middle column, and if we look on the right-hand side, we can see that Aboriginal people at 50 are recommended Prevnar, followed by 2 pneumovaxes, and older non-Aboriginal Australians at 70, so this is a new time point in the schedule, at 70 are recommended a Prevnar. And because Prevnar works better than the pneumovax, it gets much better protection, and people who are the previous schedule, so before the 1st of July, in that old world, we were giving pneumovax at 65. We don't do that, so there's no vaccines now at 65. It's all changed to 70 for non-Indigenous Australians. And the reason is because that vaccine works better. Now, the serotypes that are in the 23, that aren't in the 13, they're not so representative in that population, and we don't see a lot of people between 65 and 70 get invasive pneumococcal disease. So delaying it to 70 will give people the protection when they need it, which is in their 70s later in life. So the big changes for older Australians, and so the role of the pneumovax, the Prevnar is really important. So one of the reasons that this was done, there was a big study called the Capita study, which is community-acquired pneumonia trial in adults, and that really showed that the Prevnar gave much better protection. And for Aboriginal Australians at 50, it's been shown that the Prevnar, which works really well, plus the 2 pneumovaxes, is cost-effective in preventing invasive pneumococcal disease. So 2 of the little messages from the pneumococcal part is that the recommended vaccines and the number of doses, so it's 1 extra Prevnar followed by 2 Pneumovax 23s if you've got a risk condition, and the number of lifetime doses of Pneumovax 23 is only 2. So a lot of your patients would have already had 2, so you don't need to give them any more. If they haven't had a Prevnar, you can just give them the Prevnar. So that's pneumococcal and the changes to the schedule that came in on the 1st of July. And we'll talk about people that don't have a spleen. So you might remember this old movie, or maybe I remember it. So this is the Tin Man had no heart, the Straw Man had no brain, Dorothy had everything, she was wonderful, and the lion had no courage, so he had no spleen. But now the vaccines for the lion would be completely funded on the new schedule. So if we go back, so he'd do much better than he did in 1937 when that movie was made. Maybe that's why I remember it and the audience don't. So if we have a look at this now, so we look at now the meningococcal and the Hib, and you can see there that they're funded for people without a spleen, and the meningococcal, the big story is funded for Aboriginal kids. So the Bec 0 is included on the routine schedule for all Aboriginal children at 6 weeks and 4 months and 12 months of age. So this is absolutely fantastic. I know it's something that Katrina's been agitating for some time, and it's a credit to her work that this is now on the national schedule and funded with the data that she showed you before. And there's a catch-up for Aboriginal children, so all Aboriginal children in Australia, less than 2 years of age, for 3 years, so up until June 30, 2023, there's a free catch-up schedule. Now, you know that sometimes children who receive the Bec 0 vaccine can get a higher fever if they have their regular vaccines at the same time, so paracetamol's recommended, so you need to find solutions of getting paracetamol to those families. And this vaccine, the Bec 0 vaccine for Aboriginal kids, is not included in the no jab, no pay. So if they miss that vaccine, or if that vaccine's late, it's not jeopardising the payments. So if we look at the additional doses, so there it's 2 and 4 and 12 months, the regular ones. And if someone's got a at-risk condition, then it's Bec 0 at 2 months, 4 months and 6 months. There's an extra one there, and 12 months. So the at-risk conditions for this are for people who don't have a spleen, like we've been talking about, and also people who have a complement deficiency or are on eculizumab. So if they're on eculizumab's a bit like having a complement deficiency. So we've got no deficiency of complements for Donna and Julianne, who are waiting in the wings to do their presentation soon. But if you've got a complement deficiency, it's funded to have meningococcal, and same if you're on eculizumab, because the complement cascade, eculizumab blocks it, because the idea of that medicine is to stop destroying the red blood cells, if some conditions give you, and that will stop the cascade of complement and can decrease your immunity and open people having eculizumab to meningococcal disease. So if you read the PI, it's stated in there, so that's why that's funded for people on that monoclonal antibody. So there are only 3 conditions, so much more limited funding for people for the meningococcal than for the Prevnar that we've previously talked about. So the dosing, so the top one there is only for people who have the at-risk conditions, those 3 at-risk conditions we talked about. Then for most Aboriginal kids, it's a vaccine at 6 weeks and 4 months and 12 months. If they're starting off between 6 and 11 months, it's still 3 doses, the first 2 months apart, and the third one at least 2 months after the second one. And once they're over 12 months, it's just 2 doses 2 months apart. So that catch-up of kids up to 2 years of age. So if you're working with Aboriginal families, try to recall children that are nearly 2 so you can get that free vaccine into them. If they already 2 and you're chasing them for their second one, that's okay to give the funded vaccine. So the messages here is that the Bexsero vaccine funded for Aboriginal kids and also for people without a spleen, with a complement deficiency, and treated with the monoclonal antibody eculizumab. So just give an example of a catch-up. So this is a gentleman, aged 35, non-Indigenous, lives in New South Wales, lucky guy, and he's had tetanus vaccine in the past. So if you haven't got a spleen, you're much more likely to get a bacterial infection. So his catch-up, which is the same catch-up's always been recommended, but now these vaccines are funded. So he'd start off with a Prevnar, a Nimenrix, a Bexsero, and an Actib, and they're all funded. Then 2 months later, you'd follow it up with the second Nimenrix and Bexsero, and then somewhere between 2 months and 1 year later, he's a Pneumovax 23 to follow the Prevnar, and then at 5 yearly intervals, the Nimenrix and the second Pneumovax 23. So there's lots of good graphics in the handbook site and the Commonwealth site. I really recommend you have a look at some of these. If you think they're helpful, then hang them up around the clinic. And just to mention COVID, so there's we had a case of a positive person in the local area a bit over 10 days ago, and another one recently who gave that infection to a friend. So we've got 1 case of local transmission locally. So this is really hotting up. So it's time to be really careful. So all that social distancing, all that hard work you're doing at your clinic, keeping people sitting separately, if someone's got symptoms, wearing PPE, all that hard work now is really going to pay off. This is the time to be really, really vigilant. We had a downtime sort of 6 weeks ago when we thought, oh, this is really good, it's going to go away, we can relax a bit. Now's not the time to relax. You saw it went from Victoria from just a handful of cases to thousands of cases very, very quickly. Now they've got, I think, 20 people in ICU in Victoria. We've got the Crossroads Hotel situation in Sydney. We're following those people up. So it's really, really important that in your clinics and in your life outside work that you're absolutely vigilant about all those things, washing your hands and social distancing and protecting yourselves. And if the testing is really important. So if you see anyone with symptoms, it's really important that they get tested. In that interim between having the swab and waiting for the results, it's really important they're not out and about. If they're sick enough to be tested, they're sick enough to isolate till they get their result. And once that result's clear, that's okay. That's with people with symptoms. Different story if you're having a swab because you've been in contact with someone who's positive. If you're having a swab and you've been, not because you've got symptoms, but because you've been in contact with someone, you might have a negative swab, but the incubation period can be up to 2 weeks. So you have to isolate at home or isolate somewhere for a 2-week period. So that's a really important distinction. So if someone's been in contact with someone and they have a negative swab, that's not a clean bill of health to go out because they still might be incubating the disease. And just a little update on what's happening with vaccines around the world. So we're really hopeful that we do get a vaccine. And if we do, you guys out there who've been vaccinating for years, who have those skills, you'll be at the front line of saving the planet. So keep those vaccine skills up, really important. So with vaccines, you would have seen in the press the last few days, the University of Queensland vaccine is entering a phase 1 trial. There's 4 groups around the world that have made some progress. The Oxford and AstraZeneca vaccine, the 1222 vaccine is in a phase 2-3. They've sort of got to jump on that group there. The Imperial College group is in a phase 1-2 trial. The Moderna group you would have read about from the United States are in a phase 2 trial as well, and they're looking at announcing a phase 3 trial soon with about 30,000 participants. The Novavax one's an American company, but their first phase 1 trial is interestingly a trial of 130 volunteers in Australia. So that's sort of where we're up with vaccine, and as you know, there's over 100 candidates, so let's hope a few of them get up. But this is going to take a long time to A, develop a vaccine, then prove it's safe, and B, to manufacture it in enough volume that's going to make a difference to this global pandemic. So we're still not looking at anything happening in the very near future. But you guys are going to be on the front lines, and really thank you for your skills and thank you for listening tonight. And now a real highlight, Julianne and Donna are in Erina, waiting patiently. I know Donna's so excited, she's not nervous at all. And these guys are real clinical experts on vaccinating kids, and they're going to take you through some of the really practical aspects of vaccinating kids, especially kids who are now funded for the Bacterial vaccine in the first year of life. Thanks, Donna and Julianne.
Hi, thanks, Patty. I'd just like to let you know, so I'm the immunisation coordinator of the Central Coast, one of the 2 coordinators, we job share, and Julianne works for Child and Family Health, and she coordinates all of the child and family health clinics on the Central Coast now. And her and I and Colin Gately work together at one of the clinics on a Saturday. So we do hands-on vaccination. And so we do know the difficulties that we're facing with now the increased vaccines that we're offering. Next slide, please. I just wanted to remind everyone the place to go to find out about vaccine administration is the handbook, and that has been updated recently. So you need to be using your online version, and you can look in there and see how to prepare the vaccine, routes of administration, sites, etc., which vaccines can be co-administered, etc., and making sure that you're up to date with all of the recommendations. So just a quick reminder to be using that. I find when using the handbook, the best way at each section is to go to the expand all section up the top, that tab there, and use that so you can see where the information you're looking for is. Next slide, please. This is about the needle size and length and angle for administering vaccines. So basically the routine needle size that we recommend is 23 gauge, and you can see for an IM injection, for anybody that you're vaccinating, the only time that you would use so 25 gauge 1-inch needle, it's 25 mil. The only time you'd use a 16 mil needle, you can see there on this chart from the handbook, is if it was a very small infant, like a preemie baby, and you might need to use the very small length. But at the risk of using a smaller length than 25 mil is that you may go into the wrong part of you might not hit the muscle. You might go into the wrong part of the anatomy. You might go into the fatty tissue, and that can risk leading to an abscess. Someone very large, you may need very obese, you may need to use a longer needle, but it's not very often. You would need to vary from a 25 mil needle and a 25 gauge needle. 23 gauge, sorry, I'm saying the wrong thing. 23 gauge needle, but you can see there 23 gauge, 22 to 25 gauge needle. 23 gauge is what we recommend, and 25 mil for an IM injection. Next slide, please. This is a demonstration of what can go wrong if you give the vaccine at the wrong angle or the wrong depth or the wrong size needle. So as you can see there, intramuscular should be going in at 90 degrees. If it goes in at 90 degrees, you should hit into the muscle. The length of the needle being 25 mil. If you go in at the angle there at 45 degrees, you're going into the subcut area. So that's okay for a subcut injection, but not if you're giving IM. And if you go in any shallower, you can go into the dermal area, so into the skin. Next slide, please. So when you're giving subcutaneous immunisations, and there's not many vaccines that we give subcutaneously, most are given IM. So IPV, so IPOL vaccine, so we use this when we're doing catch-ups, that's given subcutaneously. But when you give polio as a combination vaccine, say as Infanrix Hexa, Quadricell or Infanrix IPV, then they're given IMI. Varicella vaccine, so Varilrix or Varivax is given subcutaneously, but MMRV can be given either IMI or subcutaneous. Usually when there's a choice, we recommend to give IMI because there's less likelihood of a local reaction. Some of the other examples of vaccines that are given subcutaneously are one of the Japanese encephalitis vaccines, so Imajev, and Q fever, but that vaccine is only given by specially trained providers because you have to do testing before you give the Q fever vaccine. And Zostavax vaccine is given subcutaneously as well, so at an angle of 45 degrees. Another point I wanted to make, if you are using the 25 gauge needle for an injection, making sure you give it over at a slow count of 5 so you don't risk dislodging the needle and the syringe. Next slide, please. So this is one that we get asked a lot, and we're getting asked a lot because of the changes as well. So for any infant age less than 12 months, the site that's recommended is the vastus lateralis muscle, so in the anterolateral thigh. So that's the recommended site for these IM injections. You can use the ventrogluteal area, but it must be stressed that that can only be used if you've had the special training. We've had many instances where people have thought they've given it into that area and it's actually been given into the gluteal muscle, and there's no studies on the safety and efficacy of giving a vaccine into the gluteal muscle, especially because it goes into the fatty tissue. And also it's a bit of a risk with babies because people can go too close to the developing sciatic nerve. 2 vaccines can be given into each thigh, so if you're giving them to an infant, but remembering whenever you're giving more than one vaccine into any area, you need to separate by 2.5 centimetres. So it's clear if one of the vaccines has a reaction, you can identify which vaccine caused the local reaction. Next slide, please. Okay, the diagram on the left, this shows a really good diagram from the handbook showing where to go, what the site to give the vaccine for under 12 months. And it shows that you're wanting to go straight into that muscle at an angle of 90 degrees. You can see on the right there, the other diagram shows how when you're giving a vaccine into the thigh, if you section it off into thirds, it's the middle third where you'll be giving the vaccine. So there's plenty of room there to separate by 2.5. Next slide, please. For children aged 12 months and over, the recommended site is the deltoid muscle for vaccination. If you do need to use another another site for a 12-month or more, you can use the thigh, the vastus valaris. So if you're going to use that thigh, just remember, if the child is 12 months or more, they're probably going to standing, holding onto furniture, or walking. And so it's putting extra pressure onto that muscle when they're weight bearing. So it's important to think about which is the least locally reactogenic vaccine and give that one into the thigh rather than something that might be known to cause local reactions. For example, MMR usually doesn't cause a reaction locally. It may flare up when you very first give it very briefly, but it usually subsides and doesn't have a substantial local reaction. If you use the ventrogluteal area in this age group, remember you must be trained, and remembering also the 2.5 centimetres separation. Next slide, please. So if you're giving a child at 12 months two vaccines into the deltoid, that can be done. You can see that there's plenty of room there, and most 12-monthers will have enough room. If you feel there's not enough muscle mass, or you're worried about not giving it into the right section of the deltoid, if you feel that the arm just doesn't look bulky enough, you can use the thigh, as I said. The recommendation is at 12 months with the Bexzero and the Prevnar, they should be given one in each arm. So we wouldn't be recommending to give Bexzero or Prevnar in the leg, and we certainly wouldn't recommend Bexzero and Prevnar in the same muscle, because they both are known to be locally reactogenic. The recommendation has been in the past to give Bexzero in a site on its own, and we've requested information from NCs to see if that is still the ongoing information. We've been told we will get a definite answer back in the next couple of days, and they're also working on a resource. Next slide, please. So this has been put into the handbook, and the acronym is SIRVA, so shoulder injury related to vaccine administration. And you can see the first on the left-hand side there, that first one with the cross. You can see when people don't expose their whole muscle when they're vaccinating, you can often see that you're giving it too high. And then on the second one up the top there, you can see they're giving it too low because the top hasn't been pulled up, so you can't see the whole length of the upper arm. Once you expose the whole length of the upper arm, you can see the right place to be giving it, and that's down the bottom there. There's another chart there from the handbook, the other infographic, and that is another one that reinforces. And it's a good idea to download these, laminate them, and have them in your place of vaccination, so that you can everybody can get a reminder as to where to give it. And remembering that also reinforces to expose the whole muscle, whether it be the thigh or the deltoid that you're vaccinating in. Next slide, please. So when you're giving multiple vaccinations, it is recommended that we try and give the most painful vaccine last if you're aware that one seems to be more painful than the other. And this is because when vaccinating a baby or a child, especially, if you give one that upsets them and makes them more distressed first, it's very hard to keep them positioned, and the parent starts to get more and more stressed, or the carer. Making sure that you document where you've put each vaccination so you can label it, and if they have a local AFI, you're very aware of which one was given in the upper or lower side, or which one was given in the thigh, for example. Infants less than 12 months who need 3 or 4 injections in their thigh, you would be giving 2 injections into the same anterolateral thigh, separated by at least 2.5 centimetres, or you could give, if you were trained, into the ventrogluteal area. Next slide, please. So children aged 12 months or more, adolescents or adults, the options about where you're going to give it will depend on the size of the deltoid and whether they've got a fully developed muscle there and there's enough muscle mass. The preference is to give in the deltoid wherever we can to avoid local reactions when given in the thigh. But if it's very small, as I said before, you can use the thigh or the ventrogluteal area if you're trained. Next slide, please. There are some resources put out in other states. So there's one from Victoria and one from South Australia. Here's an example here which shows you the recommendations. And so they're saying to give the Prevnar 13 and the Infinrix Hexa in one thigh and the Bex Zero separately in the other thigh. That's the recommendation at this point. And then if you're looking at the 12-month, as I said before, Bex Zero in one arm and in the other arm, Prevnar 13. They're really not wanting them given together and not in the thigh. And in this particular example, it's saying then you can give one in each thigh. So again, it depends on muscle mass. Next slide, please. So here's another one. This one's from South Australia. So again, it agrees with the one from Victoria that says Bex Zero and Prevnar to be given in the deltoids, and then MMR or Priorix, depending on what brand you have, and Nimrinix in one in each leg. Next slide, please. So just a reminder, we don't mix vaccines together, which sounds like it's pretty obvious, but we have had episodes where that's happened when people have had to give a lot of vaccines. Remembering to expose the landmarks, so the anatomical landmarks, so you can see where you're giving it and making sure you can see the whole muscle. For IM injections, we want to go at 90 degrees angle, so we're ensuring that we can get right into the muscle. And we saw a presentation recently where a baby was given the vaccine, it was Infinrix Hexa vaccine too shallowly and ended up with injection site abscesses. So that happened to the same baby twice on 2 different occasions, and it took a long time to heal. If you're using the 25 gauge needle for an IMI, which isn't the recommendation, but if you choose to, the general recommendation, you must go over a slow count of 5. Not only does that stop dislodging the syringe, the disconnection with the needle, but it also means it avoids injection pain and muscle trauma and potentially an AFib, a local AFib. Next slide, please. They're just the references. So I just wanted to clarify. So our recommendation is the 23 gauge needle, 25 mil as a routine needle for every IM injection on the schedule. Now, Julianne and I are just going to introduce this little baby who we prepared earlier, named Pineapple. And we're just going to show you how we would position a baby, because positioning is very important.
So, first things first, before we immunise a child or an infant, it's really important that we actually position the child in a nice, secure hold. In my experience with immunisation, if I've got the carer or the parent holding the child in a nice, secure hold, my job is easy. So, Donna's got a nice, secure hold here of the child, her right hand holding its right arm, and also holding the lower leg here. So the next thing important is here is, of course, I've done my hand washing. I've already done my pre-vaccination checklist. I've discussed with the parent what to expect today and what needles we're going to be given. So this child's 4 months old today. So we're going to adhere to the recommendations because this child's also going to receive the Bex Zero today. So that'll be given in a separate limb. So on the right-hand side here, I'm going to provide the Infinrix Hexa and the Prevnar vaccine. So first things first, that we're exposing the whole of the thigh here, so I can actually see. Might have to hold that up a bit, Donna.
Yeah, I normally would rest the baby on my leg, but just for the,
they can't see. You can't see that. So I've got a whole exposure of the thigh here, and sometimes that may mean that you have to undo the nappy, and that's really important because we know with parents arriving in winter, they're covered in layers of clothes, and now a few parents are now coming along with the cloth nappies now, and they do cover sort of the higher end of the thigh. So it's important to expose the thigh, to have the knee, so I can actually see the knee, the top of the thigh, and now I can locate my landmark here. So I've got the thigh muscle here, which is the vastus lateralis, which I can never say. However, and so now I can easily see that this child's muscle mass is quite sufficient to hold the two vaccinations here at 2.5 centimetres. So I'd be providing a vaccine here, providing a vaccine here, and so it's first vaccine straight in at a 90-degree angle, remembering we don't have to swab the area if it's clean. We also go in a straight 90-degree angle as well, and we don't draw back on vaccines anymore. So then I dispose of that needle. I then just hold with a cotton wool ball And I've got plenty of room now to administer my next vaccination as well. And then just providing some support to blood flow, and then turning the child around the other side. Once again, locating the thigh, the hip, nice exposure here. And what I'm only doing one sole hip right in the middle here of the muscle here, and then provide the vaccination in there exactly the same way. So right in the 90-degree angle, and just covering the blood flow. And basically, that's it. Yeah, that's us today.
That's us. Thank you.
Fantastic. Thank you, Donna and Julianne. That was absolutely brilliant. That was very practical and wonderful. Thank you very much for doing that. That's great. Well, I haven't managed the time well enough to have a question time, but if you've been putting questions in on Slido, or if you haven't, I encourage you to go to Slido. There's some wonderful questions there, and Jodie and Sharon have been answering those questions, so there's some brilliant answers. There is one question here. What if someone who had a Pneumovax at 65, do they still get a Prevnar at 70? And the answer is yes. So all the people coming through the 70 time point now, probably have already had a Pneumovax 23 at 65. They still have a Prevnar at 70. And the Prevnar, there's no upper age limit. So all people older than 70 can have a one-off Prevnar as well. So Jodie, Sharon, were there any other questions you wanted to? No? Happy? All right, well, it's 8 o'clock, so thank you very much for tuning in. Please feedback on Slido, and thank you for your time. And keep immunising with the regular vaccines, and hopefully one day in the future we'll have some COVID vaccines to be able to put an end to this terrible pandemic. So take care of yourselves, look after yourselves, wash your hands, look after your mates. And thank you to all the presenters tonight. Good night.